Let's talk about ovarian position. Ovary is kept in position by broad ligament and mesovarium. After pregnancy, the broad ligament is lax and the ovaries may prolapse into the rectouterine pouch. In these circumstances, the ovary may be tender and cause discomfort on sexual intercourse, which is dyspareunia. An ovary situated in the rectouterine pouch may be palpated through the posterior fornix of the vagina. Now let's talk about ovarian cysts. So follicular cysts are common and originate ruptured Graafian follicles. They rarely exceed 0.6 inches in diameter. Now let's talk about luteal cysts, which rarely exceed 1.2 inches in diameter. So luteal cysts are going to be bigger. Luteal cysts are formed in the corpus luteum. Fluid is retained and the corpus luteum cannot be fibrosed. Now let's talk about uterine tube as conduit for infection. Uterine tube lie in the upper free border of the broad ligament and it is a direct route of communication from the vulva through the vagina and uterine cavity to the peritoneal cavity. So now let's talk about pelvic inflammatory disease. So pathogenic organisms may enter the body through the sexual contact and ascend through the uterus and enter the uterine tubes. So what happens is that salpingitis may follow. Leakage of pus into the peritoneal cavity causing pelvic peritonitis. Pelvic abscess usually follows, or the infection spreads farther, causing general peritonitis. Talk about ectopic pregnancy, which is implantation and growth of fertilized ovum, which may occur outside the uterine cavity in the wall of the uterine tube. This is a variety of ectopic pregnancy because there is no residual formation in the tube and because of the eroding action of the trophoblast, which destroys the wall of the tubes. Tubal abortion or rupture of the tube is going to result in effusion of a large quantity of blood into the peritoneal cavity. As a result, the blood pours down into the rectouterine pouch, which is the pouch of Douglas, or into the uterovesical pouch. The blood may quickly ascend into the general peritoneal cavity, giving rise to severe abdominal pain, tenderness, and guarding irritation of the SDP, which is subdiaphragmatic peritoneum supplied by the phrenic nerves C3, C4, and C5, may give rise to referred pain to the shoulder skin through the supraclavicular nerves C3 and C4. Now let's talk about ligation of the tube. Ligation and division of the uterine tube is a method for obtaining permanent birth control. The ova that are discharged from the ovarian follicles degenerate in the tube, which is distal to the obstruction. If later the woman wishes to have children, restoration of the tube may be attempted, and in 20% of women, fertilization. Now let's talk about bimanual uterine pelvic examination. It can provide a great deal of useful information about the state of uterus, uterine tubes, ovaries. Examination is easiest in Paris women who are able to relax while the examination is in progress. It may be performed under an anesthetic in patients in whom it can cause distress with the bladder empty. In the vaginal position of the cervix is first palpated with the right hand index finger. You're going to palpate the vaginal portion of the cervix. External os is circular in nulliparous women, but it has anterior posterior lips in multiparous women. Cervix normally has a consistency of the end of the nose, but in the pregnant uterus it is soft and vascular, like the consistency of the lips. Left hand is placed gently above the symphysis pubis on the anterior abdominal wall. And the fundus and the body of the uterus may be palpated between the abdominal and vaginal fingers situated in the anterior fornix. So then, with the hands in those positions, you can actually palpate the anterior fornix. The size, shape, and mobility of the uterus can be ascertained through that. In most of the women, uterus is anteverted, and anteflexed retroflexed uterus can be palpated through the posterior vaginal pharynx. So now let's talk about varicose veins and hemorrhoids in pregnancy. Varicose veins and hemorrhoids are common conditions in pregnancy. The following factors contribute to them: the pressure of the gravid uterus on the inferior vena cava and the inferior mesenteric vein on IVC and IMV, impairment of the venous return, and increased progesterone levels in the blood, leading to relaxation of the smooth muscle in the walls of the veins and hence venous dilatation. Now let's talk about emergency cesarean section. Emergency C-section is rarely performed. However, a physician may need to perform this surgery in cases in which the mother may die after suffering a severe traumatic incident. Following the maternal death, placental circulation ceases and the child must be delivered within 10 minutes. Neonatal survival is rare after a delay of more than 20 minutes. So now let's talk about the anatomy of the technique of the C-section. The bladder is going to be emptied and an indwelling catheter is left in position. This allows the empty bladder to sink down away from the operating field. Now let's talk about where are we gonna make the incision. Incision is going to be made that extends just below the umbilicus to just above the pubic symphysis. Talk about the structures which have to be incised. So for that we have LTEP. So we are gonna incise the linea alba, then we are gonna incise the transversalis fascia, and then we are gonna incise the extraperitoneal fatty layer, and then the parietal peritoneum to avoid damaging the loops of the small intestine or the greater omentum, which are present posterior to the uterus. The small intestine or greater omentum, which might be lying beneath the parietal peritoneum, a fold of peritoneum, which is raised between two hemostats, and incision is going to be made between the hemostats. the bladder is identified and a cut is made in the floor of the uterovesical pouch. First of all, what are you gonna see anteriorly? Of course, anterior to the uterus, you're gonna see the uterovesical pouch. So, wahan par you're gonna make a cut. The bladder is then separated from the lower part of the body of the uterus and depressed downwards into the pelvis. Then the uterus is palpated to identify the presenting part of the fetus. A transverse incision about 1 inch long is made into the exposed lower segment of the body of the uterus. Care is taken that the uterine wall is not immediately penetrated and the fetus is injured. When the uterine cavity is entered, amniotic cavity is opened and amniotic fluid is going to spurt out. Uterine incision is then enlarged sufficiently to deliver the head and the trunk of the fetus. When possible, the large tributaries and branches of the uterine vessels in the myometrial wall are avoided. Great care has to be taken to avoid the large uterine arteries to cross that course along the lateral margin of the uterus. Once the fetus is delivered, the umbilical cord is clamped and divided. The contracting uterus will cause the placenta to bulge through the uterine incision. The placenta and the fetal membranes are then delivered. Uterine incision is closed with the full thickness continuous suture. The peritoneum over the bladder and lower part of the uterine body are then repaired to restore the integrity of the UV pouch or uterovesical pouch. Finally, the abdominal wall incision is closed in layers. Now let's talk about uterine prolapse. So for this, please remember SPF in LA. Okay, so first of all, levator ani muscle, and second of all, subcutaneous pelvic fascia. So levator ani muscle and the subperitoneal facial ligaments are critical in supporting the uterus and in positioning of the cervix within the pelvic cavity. Damage to the levator ani or damage to the subperitoneal pelvic facial ligaments during childbirth and general poor body muscular tone may result in downward displacement of the uterus called uterine prolapse. This condition occurs mostly after menopause when the visceral pelvic fascia tend to atrophy along with the pelvic organs. In advanced cases, the cervix descends the length of the vagina and may protrude through the orifice. Because the cervix is attached to the vault of the vagina, prolapse of the uterus is always accompanied by some degree of the prolapse of vagina. Now let's talk about hysterectomy and damage to ureters. During the surgical procedures of hysterectomy, great care must be exercised to not damage the ureters. When the surgeon is looking for the uterine artery, he should first look for the ureter. When he's looking for the uterine artery on each side of the base of the broad ligament, it is essential that he should identify the ureter. Before clamping and tying off the uterine artery passes forward from the internal iliac artery and crosses the ureter at right angles to reach the cervix at the level of the internal os. Now let's talk about examination of the vagina. So anatomical relations of the vagina are of great importance when we are performing examination of the vagina. Many pathological conditions occur in the female pelvis. They may be diagnosed by using a simple vaginal examination. The following structures can be palpated. So anteriorly, the bladder and bladder above, urethra below. Posteriorly, what do we have? We have the loops of ileum and sigmoid colon. And so posteriorly, we have loops of ileum and sigmoid colon in the rectouterine peritoneal pouch, which is pouch of Douglas, the rectal ampulla, and the perineal body. So what do we have laterally? Laterally, on the upper part, we have the ureter. In the middle part, we have the puborectalis, and the lower part, we have the urogenital diaphragm and the bulbar vestibule, and also the anterior fibers of the levator ani muscle. Now let's talk about vaginal prolapse. Vaginal vault is supported by the same musculature and facial structures that support the uterine cervix. Thus, prolapse of the uterus is necessarily associated with some degree of the sagging of the vaginal walls. However, if the support of bladder, urethra, or the anterior rectal wall is damaged during childbirth, prolapse of the vaginal walls can also occur with the uterus remaining in the correct position. Sagging of the bladder results in bulging of the anterior wall of the vagina, a condition which is known as cystocele. And then, so please remember BV for that. Okay, now, when the ampulla of rectum sags against the posterior wall of vagina, the bulge is going to be called as rectocele. Now let's talk about something which is called culdocentesis. The closeness of the peritoneal cavity to the posterior fornix of the vagina enables the physician to drain a pelvic abscess to the vagina without performing a major operation. It is also possible to identify blood or pus in the peritoneal cavity by passing a needle through the posterior fornix. Let's talk about anatomical structures through which needle passes. Needle is going to pass through the mucous membrane of the vagina, the muscular cord of the vagina, the connective tissue of the vagina, and the visceral layer of the pelvic fascia, and the visceral layer of the peritoneum. So mucous membrane, muscular cord, connective tissue, and then we have visceral layer of pelvic fascia and the visceral layer of peritoneum. Talk about anatomical features of complications. Needle could impale the loops of ileum and sigmoid colon, which are present posteriorly in the rectouterine pouch. However, the presence of blood or pus within the pouch will deflect the viscera superiorly. Also, occasionally, when the uterus is somehow retroflexed, needle may penetrate the posterior wall of the body of the uterus. Now let's talk about trauma to the vagina through picket fence injury, coital injury, and vaginal perforation, or through water under pressure, as in water skiing. There are common injuries. Lacerations of the wall of the vagina involving the posterior fornix may violate the rectouterine pouch of the posterior of the peritoneal cavity and cause prolapse of the small intestine into the vagina. Now let's talk about visceral pelvic fascia infection. Clinically, pelvic fascia in the region of the uterine cervix is called the parametrium. It is a common site for the spread of acute infections from the uterus and the vagina, and here the infection often becomes chronic, which is PID, which is pelvic inflammatory disease. Now let's talk about rectouterine pouch and disease. Because the rectouterine pouch that is the most inferior part of the entire peritoneal cavity when the patient is in the erect or standing position, it is frequently the site for the accumulation of blood and pus. Accumulation of blood from a ruptured ectopic pregnancy or pus from a ruptured pelvic appendicitis or gonococcal peritonitis. Because the pouch lies directly behind the posterior fornix of the vagina, it is violated by misguided instruments that pierce the wall of the posterior fornix. Pelvic peritonitis is a danger that may ensue. A needle may pass into the pouch through the posterior fornix in cultocentesis. Surgically, the pouch may be entered in a posterior colpotomy, which is vaginal incision. The interior of the female pelvic peritoneal cavity may be viewed for evidence of disease through an endoscope. This instrument is introduced through a small colpotomy. Now we are going to talk about something which is called prostate examination. Prostate can be examined clinically by palpation by performing a digital rectal examination. The gloved finger of the examiner is going to feel the posterior surface of the prostate through the anterior rectal wall, PPAR. Okay. Now let's talk about the activity of prostate and disease. So androgens and estrogens circulating in the bloodstream are thought to control the normal glandular activity of the prostate. Secretions of the prostate are going to pour into the urethra during ejaculation and add to the seminal fluid. Acid phosphatase is an important enzyme present in the secretion in large amounts. When the glandular cells producing acid phosphatase cannot discharge their secretions into the duct, as in the carcinoma of the prostate, the serum acid phosphatase level is going to increase in the blood. So, trace amounts of proteins produced specifically by prostatic epithelial cells are found in the peripheral blood. So, proteinemia is going to occur. In certain prostatic diseases, notably cancer of the prostate, protein appears in the blood in increased amounts. Specific protein level can be measured by a lab test which is called FSA test. Now let's talk about very important thing which is benign prostatic enlargement. So, benign enlargement of the prostate is common in men above 50 years of age. This cause is probably because of imbalance in the hormonal control of the gland of the prostate. Median lobe of the gland is going to enlarge upward and it is going to encroach within the sphincter vesicae, which is located at the neck of the bladder. So this is the sphincter vesicae. So here we can see that the median lobe has enlarged a lot and it is going to encroach the sphincter vesicae, which is located at the neck of the bladder, and leakage of urine is going to occur into the prostatic urethra, and there is going to be an intense reflex desire to micturate. Enlargement of the median lobe as well as enlargement of the lateral lobe of the gland is going to produce elongation and lateral compression as well as distortion of the urethra, so that the patient is going to experience difficulty in passing of urine and the stream is going to be very weak. Back pressure effects on the ureter and both of the kidneys are a common complication. Now let's talk about the enlargement of the uvula vesicae, which is very important as shown in the picture. So the enlargement of the uvula vesicae is due to the enlargement of the median lobe. It is due to the formation of a pouch of stagnant urine which is present behind the urethral orifice within the bladder. The stagnant urine is going to become infected frequently and the inflamed bladder is called cystitis. It adds to the patient's symptoms. The surgeon regards the prostatic venous plexus with respect in all the operations on the prostate. Veins have thin walls, they are valvulous, and they are drained by several large trunks directly into the internal iliac veins. Damage to these veins can result in severe hemorrhage. Now let's talk about prostate cancer and prostatic venous plexus. Many connections exist between the prostatic venous plexus and the vertebral veins. During coughing, abdominal straining, and sneezing, it is possible for prostatic venous blood to flow in a reverse direction towards the vertebral veins. This explains the frequent occurrence of skeletal metastasis in the lower vertebral column and the pelvic bones of the patients with carcinoma of the prostate. Cancer cells can enter the skull through this route by floating up the valvulus, prostatic, and vertebral veins. Let's talk about circumcision. So circumcision is the operation of removing the greater part of the prepuce or the foreskin. In many newborn males, the prepuce cannot be retracted over the glans. This can result in infection of the secretions which are present beneath the prepuce, leading to inflammation, swelling, and fibrosis of the prepuce. So repeated inflammation is going to lead to constriction of the orifice of the prepuce or the phimosis with obstruction of urination. So the current general belief is that chronic inflammation is going to lead to carcinoma of the glans penis. For these reasons, prophylactic circumcision is commonly practiced. It is a religious rite in certain beliefs as well. Now let's talk about catheterization. Okay, so external orifice at the glans penis is the narrowest part of the entire urethra. Within the glans penis, the urethra is going to dilate to form the fossa terminalis or the navicular fossa. Near the posterior end of the fossa navicularis, a fold of mucous membrane is going to project into the lumen from the roof. The intermediate or the membranous part of the urethra is the narrow and fixed part. The prostatic part of the urethra is the widest and most dilatable part of the urethra. By holding the penis upward, S-shaped curve to the urethra is going to be converted into a J-shaped curve. If the point of the catheter passes through the external orifice and then directly towards the urethral floor until it has passed to the mucosal fold, it should easily pass along a normal urethra into the bladder. So now let's talk about the anatomy of the procedure. So the patient is lying in supine position. With gentle traction, the penis is held erect at a right angle to the anterior abdominal wall. The lubricated catheter is passed through the narrow external urethral meatus, so M for meatus, and catheter should pass easily along the penile urethra, and then M and P. And then it is going to reach the membranous urethra, MPM of the a slight resistance is felt when it reaches the membranous urethra because of the tone of the external urethral sphincter and the surrounding rigid perineal membrane. Then the penis is lowered towards the thighs and the catheter is gently pushed through the sphincter. Passage of the catheter through the prostatic urethra and the bladder neck should not present any difficulty. Now let's talk about urethral infections. The most dependent part of the male urethra is that which lies within the bulb of the urethra. Here it is subject to chronic inflammation and stricture formation. The many glands that open into the urethra, including those of the prostate, bulbourethral glands, and many small penile urethral glands, are commonly the site of chronic gonococcal infection. Injuries to the penis may occur as a result of blunt trauma, penetrating trauma, or strangulation. Amputation of the entire penis should be repaired by anastomosing. The microsurgical techniques to restore the continuity of the main blood vessels. Now let's talk about rupture to urethra. So the rupture of the urethra may complicate a severe blow on the perineum. The most common site is the bulb of the penis, just below the perineal membrane. So extravasation of urine कहाँ पर होगी? First of all, it is gonna enter into the superficial perineal space or the superficial perineal pouch, and then it is going to pass over the scrotum beneath the membranous layer of the superficial fascia, SSM. As if the intermediate part of the urethra or the membranous part of the urethra is ruptured, then the urine is going to escape into the deep perineal pouch and extravasate either upwards around the prostate and the bladder, or it may go downward into the superficial perineal space. Now let's talk about erection and ejaculation after spinal cord injuries. So parasympathetic nerves that originate from the second, third, and fourth sacral segments of the spinal cord will control the erection. Bilateral damage to the reticulospinal nerve tracts in the spinal cord will result in loss of erection. Later, when the effects of spinal shock have disappeared, spontaneous or reflex erection may occur if the sacral segments of the spinal cord are intact. Sympathetic nerves that originate in the L1 and L2 of the spinal cord will control ejaculation. As in erections where bilateral damage to the spinal cord results in loss of ejaculation, later on reflex ejaculation may be possible in patients with spinal cord transection in the cervical and thoracic regions. Vulval infection. The presence of numerous glands and ducts opening onto the surface of the vulva will make this area prone to infection. The sebaceous glands of the labia majora, the ducts of the greater vestibular glands, the vagina, which is in indirect communication with the peritoneal cavity, in the urethra and the lesser vestibular glands or the periurethral glands, they can all become infected. The vagina itself has no glands and it is lined with stratified squamous epithelium. The pH of the interior is kept low. It is capable of resisting infection to a remarkable degree. Now let's talk about vulva and pregnancy. So, important sign in the diagnosis of pregnancy is bluish discoloration of the vulva and the vagina as a result of venous congestion, seen typically in the 8th to 12th week and increases as the pregnancy progresses. Now let's talk about urethral infection. Short length of the female urethra predisposes to ascending infection. Consequently, cystitis is more common in females as compared to males. Now let's talk about injury to urethra. These are rare because of short length of the urethra and fractures of the pelvis. Shearing forces may damage the urethra as it emerges from the fixed perineal membrane. Now let's talk about catheterization, which is relatively easier in females because the urethra is shorter, wider, and more dilatable. Catheterization is much easier. The urethra is straight and only minor resistance is felt as it passes through the external urethral sphincter. Now let's talk about examination of the vagina. So digital examination of the vagina may provide the physician a lot of information concerning the health of the walls of the vagina, uterus, and surrounding structures. Now let's talk about perineal injury during childbirth. So perineal body is a wedge of fibromuscular tissue that lies between the lower part of the vagina and the anal canal. It is held in position by the insertion of the perineal muscles and attachment of the levator ani muscles. It is a much larger structure in female as compared to males. It provides support to the posterior wall of the vagina. Damaged by laceration during childbirth can be followed by permanent weakness of the pelvic floor. Few women escape injury. In most of the women, there is a little more than an abrasion of the posterior vaginal wall. Spontaneous delivery of the child without midwife or when the patient is unattended can result in a severe tear of the lower third of the posterior wall of the vagina, perineal body, and the overlying skin. In severe tears, the laceration may extend into the anal canal and also damage the external sphincter. In these cases, it is imperative that accurate repair may be extended, and in these cases, it is imperative of the wall of the anal canal, vagina, and perineal body. In the management of childbirth, when it is obvious that to the obstetrician that the perineum will tear before the baby's head emerges, what do you do? Through the vaginal orifice, a planned incision is made through the perineal skin in a posterolateral direction to avoid the anal sphincters. This is the episiotomy. Breech deliveries and forceps deliveries are usually preceded by episiotomy. Now let's talk about pudendal nerve block. The area which is anesthetized is the skin of the perineum. However, nerve block does not completely abolish sensation from the anterior part of the perineum, which is also innervated by the ilioinguinal and the genitofemoral nerves. It also does not abolish pain from the uterine contractions that ascend to the spinal cord through the visceral afferent nerves that follow the sympathetic nerves. Now let's talk about the indications. During the second stage of labor, which is a very difficult stage, when the presenting part of the fetus, which is usually the head, is descending through the vulva, forceps delivery and episiotomy may be necessary. Episiotomy is of two types: transvaginal and perineal procedure. For the transvaginal procedure, just remember the bony landmark of ischial spine. So we're going to insert our index finger to the vagina to palpate the ischial spine, and then the needle of the syringe is going to be inserted. It is going to pass through the vaginal mucous membrane towards the ischial spine, and on passing through the sacrospinous ligament, the anesthetic solution is injected through the pudendal nerve. Now let's talk about the perineal procedure. So bony landmark for the perineal procedure is going to be ischial tuberosity, PIT. The tuberosity is palpated subcutaneously through the buttock, and the needle is inserted into the pudendal canal along the medial side of the tuberosity. The canal is going to lie about 1 inch deep to the free surface of the ischial tuberosity. Local anesthetic is then infiltrated around the pudendal nerve.